Welcome, everyone. We're doing a deep dive today into transplant immunology, really focusing on what you need to know for board exams, especially around allograft rejection.
Exactly. Understanding these immune responses as well, it's just fundamental for successful transplantation, managing grafts, everything really.
Okay, so let's start with the basics, the types of grafts. We've got grafts needing vascularization, obviously,
Right.
then autografts, patient's own tissue.
Right. And allografts from another person. Isografts, identical twins, and xenografts, different species entirely.
And within that, you mentioned vascularized grafts needing that vessel hookup and composite grafts, which is, multiple tissue types together.
Like in VCA.
Precisely.
Yeah.
Face, hand transplants, that kind of thing.
Now, central to allograft rejection is the MHC, the major histocompatibility complex, or in humans, HLA, human leukocyte antigens.
Mm-hmm. These are like the body's ID tags. They're crucial for the adaptive immune system, and differences here are the main driver for rejection. They're essentially our immunologic fingerprint. And these HLA molecules, they fall into two main classes, right? Class 1.
Yes, class I includes HLA-A-B and DA. These are found on pretty much all nucleated cells. Their job is showing peptides from inside the cell.
Okay, intracellular stuff. And class 2.
Class 2, that's HLA-DP-DQ-DR. These are mostly on antigen-presenting cells.
Mm-hmm.
Think monocytes, macrophages, dendritic cells, B cells. They display peptides from outside the cell that have been processed.
Got it. So the adaptive immune system is really the star player in rejection. Lymphocytes, B and T cells, they're the key mediators with specific antigen receptors.
Right, and P cell activation is not just one step. It needs three signals, essentially.
Okay, signal 1.
That's the T cell receptor recognizing the foreign antigen presented on the MHC molecule. You have CD8 on cytotoxic T cells interacting with MHC class 1.
And CD4 on helper T cells with MHC class 2, stabilizing that interaction.
Exactly. Then you need signal 2, the costimulatory signal. Can't get full activation without it.
And signal 3.
That's cytokine release. IL-2 is a big one. This drives the T cell to multiply, change, and get ready to, well, do its job. Its effector function.
So what are these effector functions? CD8 cells.
Those are your cytotoxic T cells, the direct killers. They find cells showing foreign antigen on MHC class I and destroy them.
And the CD4 helper cells.
They're more like the conductors. They release cytokines that activate other immune cells, boosting both antibody production, humoral immunity, and cell-killing activity.
Okay, so how does the recipient's body actually recognize the donor organ as foreign? Two pathways, I believe.
That's right. First is the direct pathway. Donor antigen-presenting cells actually travel to the recipient's lymph nodes and stimulate the recipient's T cells directly.
Like the donor cells are raising the alarm themselves.
Pretty much. And this direct route is thought to be dominant in early acute rejection.
Okay. And the indirect pathway.
That's different. Here, the recipient's own antigen-presenting cells pick up donor antigens, maybe bits shed from the graft, process them, and then present those fragments to the recipient's T cells.
Ah, okay. So the recipient's cells are doing the presenting.
Exactly. And this pathway is considered more important for chronic rejection down the line.
Right. Let's talk about the types of rejection based on timing and mechanism. Hyperacute rejection.
The fastest one. Minutes to hours post-transplant. It's bad news.
Caused by.
Pre-existing antibodies in the recipient against donor antigens, often ABO mismatches or previous sensitization. These antibodies hit the donor endothelium, trigger complement, coagulation, basically the vessels clot off.
And prevention is key here.
Absolutely. ABO matching, cross-match assays, mixing recipient serum with donor cells to check for lysis and PRA testing, panel reactive antibody to see what percentage of the population the recipient might react to.
Then there's accelerated rejection.
Yeah, this happens in the first few days. It's like a memory response.
Mm-hmm.
Memory T cells that have seen similar antigens before get rapidly reactivated.
Treatment for that.
Usually high-dose steroids, maybe lymphocyte-depleting agents to knock down that rapid response.
Okay, moving on to acute rejection. This is more weeks to months later.
Typically, yes. It's essentially inflammatory damage to the graft. And we split this into two types based on the main culprit.
Acute cellular rejection.
That's T-cell mediated. T cells directly infiltrate and attack the graft tissue.
And treatment.
Pulse steroids are usually first line.
Mm.
Then you optimize their baseline immunosuppression. Sometimes lymphocyte-depleting agents if it's severe or resistant.
And the other type? Acute humoral rejection.
Antibody-mediated. B cells produce antibodies that target the graft.
Treatment for that is different then.
Yeah, you need to target the antibodies and the B cells. So things like plasmapheresis to remove antibodies, IVIG, and rituximab, which depletes B cells.
But it's important to note, for VCA specifically, we mostly see and report the cellular type of acute rejection, right?
That's the current understanding, yes. Acute cell-mediated rejection is the primary type described in VCA.
What about chronic rejection, the long-term problem?
This develops over months to years. It's insidious. The hallmark is this chronic vasculopathy disease of the graft blood vessels.
Leading to fibrosis.
Exactly. You get endothelial injury, smooth muscle cells proliferate, the vessel wall thickens, narrows, eventually blocking blood flow, leads to graft failure. And unfortunately, we lack really good treatments once it's established.
Are there known risk factors, immunologic ones?
Definitely. Things like having had prior acute rejection episodes, being sensitized, maybe inadequate immunosuppression levels over time.
And non-immunologic factors play a role too, at least in solid organs.
Yes. Ischemia time, how long the organ was without blood supply. Donor factors like brain death can have an impact, and the recipient's own health, comorbidities.
But again, for VCA, chronic rejection isn't really a clearly defined entity yet.
That's correct. While late graft deterioration can occur, the classic chronic rejection vasculopathy seen in solid organs hasn't been definitively confirmed in VCA.
Let's briefly touch on the innate immune system. Its role is maybe less defined.
Less specific than the adaptive system, certainly, but it's involved. It often gets activated by the adaptive response or by tissue damage itself.
So components like neutrophils, macrophages, NK cells.
Complement. Pattern recognition receptors, like toll-like receptors, TLRs. These TLRs recognize pathogen patterns, but also signals from damaged self-tissue damage-associated molecular patterns, or DAMPs.
So in transplant, the innate system gets recruited by the adaptive signals and also by sensing the injury within the graft.
That seems to be the case, yes.
Yeah.
It contributes to the inflammation.
Okay, let's just shift focus specifically to vascularized composite allografts, VCA, multiple tissue types transferred together.
Right. Skin, muscle, bone, nerve. The whole package is a functional unit.
And a key advantage, especially for us as surgeons, is the skin component, isn't it?
Absolutely. You can directly see potential rejection early on by looking at the skin. It's a huge advantage over solid organ transplants where you often need a biopsy.
Because the skin is highly antigenic.
Very. It's often the first and main target in acute rejection. We look for those telltale signs, red patches, macules, maybe some raised papules.
And there's a grading system for this. BAMF.
Yes. The BAMF 2007 scheme is used for VCA. It grades acute rejection histologically from grade 0, meaning minimal inflammation, up to grade 4th, which involves significant tissue damage like epidermal necrosis.
And just to reiterate, chronic rejection not clearly defined in VCA.
Correct. Still an area of study.
Given the antigenicity, immunosuppression is obviously critical for VCA. Let's talk about the phases. Induction therapy.
Given right around the transplant time, the goals are to prevent acute rejection, or at least lessen its severity, and hopefully minimize early steroid doses.
What kind of agents are used?
Often potent ones. Polyclonal antibodies like antithymocyte globulin, ATG, or monoclonal antibodies targeting the IL-2 receptor like basiliximab, or sometimes anti-CD3 antibodies.
But these come with risks.
They do. Increased risk of infection is a major one, and also PTLD, post-transplant lymphoproliferative disease. It's a balance.
Then comes maintenance therapy. This is lifelong.
Lifelong? Yes. The aim is to keep the immune system suppressed enough to prevent rejection, but not so much that the patient can't fight infections or survey for cancer. It's a tightrope walk.
And the typical regimen, often a 3-drug combo?
Usually. A calcineurin inhibitor, like tacrolimus or cyclosporine, is often the cornerstone, plus an antimetabolite, like mycophenolate mofetil or azathioprine, and often a corticosteroid, though we try to minimize or withdraw steroids if possible.
What happens if rejection occurs despite maintenance? Rescue therapy.
Right. If acute rejection happens, first line is usually to hit it hard with high-dose corticosteroids, like a steroid pulse. Also, optimize the calcineurin inhibitor levels, make sure they're therapeutic. And for skin rejection in VCA, topical immunosuppressants can be very helpful.
And if that doesn't work, second line.
Then you might escalate, maybe go back to some of the induction agents like ATG or switch things up, perhaps adding sirolimus or using higher doses of tacrolimus.
Of course, all these drugs have side effects and long-term risks.
Absolutely. Besides the specific side effects of each drug class, the overall state of immunosuppression increases the risk of opportunistic infections and certain malignancies.
Which malignancies are most common?
Skin cancers are significantly increased, especially squamous cell carcinoma, SCC, and PTLD, that lymphoma linked to the Epstein-Barr virus, is also a serious concern.
Okay, finally, let's just touch on tolerance. Self-tolerance first, the body not attacking itself.
Right, that's established centrally in the thymus, where self-reactive T cells are deleted, and peripherally through mechanisms like deletion, anergy, or suppression by regulatory T cells. When this breaks down, you get autoimmunity.
But in transplantation, we're aiming for donor-specific tolerance.
Exactly, that's the ultimate goal. The recipient accepts the graft without needing global immunosuppression, but can still fight off everything else. Long-term survival, no drugs.
How close are we? What are the strategies being explored?
Well, it's challenging. Ideas include things like inducing T cell depletion early on, using regulatory T cell therapy to actively suppress the anti-donor response, blocking those costimulatory signals we talked about, or inducing what's called mixed chimerism, often via a combined bone marrow transplant.
Fascinating stuff. So just to quickly summarize, we've covered the immune players, adaptive and innate, the recognition pathways, direct and indirect, the different flavors of rejection, hyperacute, accelerated, acute, cellular and humoral, and chronic, especially in the VCA context. Plus, the essentials of immunosuppression and this idea of tolerance.
hmm And having a solid grasp of all this immunology is just crucial for anyone involved in plastic surgery transplantation. It guides how we manage patients, how we spot rejection, how we treat it.
Absolutely. And looking ahead, the push towards achieving true donor-specific tolerance, well, that really represents the future, doesn't it? Potentially changing the whole landscape of transplantation, if we can get there.